Good evening, everybody. Once again, welcome to the FRCS Mentor webinar session. As always, we have an excellent talk for you, and we will also have Viva sessions in the non-recorded part of the section. Today we have Srikanth Gandavaram. He's one of our new mentors, joined us in 2020. We're very proud of him and his work. He has an interest in, he's a senior specialist with an interest in sports knees and lower limb arthroplasty, and we're lucky to have him to talk to us about knee dislocation and multi-ligament knee injury.
For the introduction, let me start off with the topic. As described, we're doing a knee dislocation presentation and multi-ligamentous knee injury. My talk is around 20-25 minutes. This whole presentation is focused around FRCS exam. Hopefully, and I'm pretty hopeful, by the end of this presentation and discussion, you should be able to answer any questions around knee dislocation and confidently. Okay. Knee dislocations, as you're aware, it's a very rare injury. Almost about 0.02% to 0.2% of all the orthopedic injuries. However, the true number may well be higher, because about 50 to 60% of the cases, the knee spontaneously reduce, and that's why you don't have the true number. Knee dislocations, why are they so serious? Because of the neurovascular structures around the knee. It can have a limb-threatening short-term complications, which may end up in amputations and unable to use the knee because of the nerve injuries and things, and the long-term consequences from the result of multi-ligamentous knee injury and associated neurology. So what is the mechanism involved? The most common mechanism is high velocity injuries, and the second most being sports injuries. You see these in contact sports, rugby, football, skiing injuries, ice skating, ice hockey. These are the injuries that you commonly see in these kind of contact sports. Interestingly, the low velocity injuries as well in in morbidly obese patients. And also it is interesting that the neurovascular injury is no different from the high velocity or sports knee injuries compared to low velocity injuries. Okay, coming to the classification, what does the classification tell? Classification mainly guides us. Classification gives us the nature of problem. If you see Kennedy's classification, which basically tells about the mechanism of injury, where it is anterior dislocation or posterior dislocation, medial lateral, and rotatory dislocations. It also tells, if you see the anterior and posterior, it's gone in the sagittal view. So basically tells it may be the cruciates that are gone, and it can tell you that likely that there may be an arterial injury or at least significant threatening to the neurovascular structures. Medial lateral and rotatory gives us an information about the ligament rupture. Maybe the both cruciates are gone, and the collateral ligaments also would be involved. Schenck classification is more like a grading system. It gives us an idea about how to manage this and guide us in the management, as well as to an extent it helps us in prognosis as it goes from top to bottom, KD1 to KD5, it only worsens. If you start with KD1, it's only one of the cruciates that are gone. KD2 is bicruciate. KD3 is more important because it constitutes about 65% of the dislocations. So KD3, where you have, if KD3M meaning there is medial collateral ligament being injured, KD3L, which says posterolateral ligament being injured. KD4, which has bicruciates and both collateral being gone, and KD5, there is periarticular fracture dislocation. What are the immediate complications? As we expected, vascular injury is most common, average about 30 to 40%. Popliteal artery is the most commonly injured. Why is popliteal artery most commonly injured? Because it's relatively fixed and it is posterior to the knee. Why is it fixed? It is fixed at the adductor hiatus proximally, and distally it is relatively fixed at the soleus tendinous junction. And therefore, it makes it relatively fixed, and therefore it is subjected to shear forces when the knee dislocation happens. As you can see, highest incidence could more likely be in posterior dislocation. And to be honest, anterior dislocations are equally can equally cause injuries to the popliteal artery. The importance in detecting or diagnosing a vascular injury is crucial. Failure or delay in the diagnosis of vascular injury can lead to a significant rise of amputation rates. As you can, the literature says if it is beyond 8 hours, the risk of amputation is about 86%, which is very high. Okay, coming to the next injury, which is nerve injury. The common peroneal nerve is the most common injury. Why common peroneal nerve? It is also relatively fixed because it is fixed proximally at the fibular neck and distally at the intermuscular septum, making it more rigid and therefore being subjected to shear forces during dislocation. It can most commonly occur in posterolateral knee dislocations. However, you can't rule out a nerve injury based on a dislocation. It only comes down to examination to rule out a common peroneal nerve injury. Studies have shown that 21% of the patients do recover fully, partially in 29%, about 50% of the people do not recover at all. So, for them further needing a nerve repair, grafting, or in worst case scenario, if it doesn't recover by the end of the year, they may need tendon transfers. And the other most deadly complication is compartment syndrome, which we all are aware of, and we know that we act promptly. But the things that we miss is a vascular injury in case of a dislocation which spontaneously reduced, so we don't really see that coming. Okay, what do we do in the emergency department? This is something which is most important. I will go through this a little bit more in detail. You see on this the slide on the left, the picture on the left, it is more or less widely used approach or algorithm in knee dislocations. Let's say a patient with a knee dislocation or a knee injury is in the emergency department. How do you approach? You approach with the ATLS protocol, no different from any trauma injury. You clear A, B, C, and come to the deformity. If you see a deformity, check for the pulse, check for the neurology, get an urgent X-ray. If there is a dislocation, reduce the dislocation, splint the limb, and then do the regular examination. What do we do? You just need to check the distal pulse, put the cuff before applying the splint so that you don't have to keep removing it. Check the ABPI, ankle brachial pressure index. It is one of the most rapidly usable and reliable method. Let's say you reduced it, pulse has come back, and you regularly monitor the ankle brachial pressure index for about 48 to 72 hours, up to 72 hours. And if there is any change, you will have to do any further imaging to see if there is any blockage of the artery or bleeding. So let's say if there is a pulse asymmetry, or if there is if the ankle brachial pressure index is less than 0.9, then you have to involve the vascular surgeons, get an urgent arteriogram, prepare him for surgery, for nerve repair, or for the vascular repair or a reconstruction, plus minus X fix. Let's say there is no pulse at all after reduction. You have no other option but to take him straight to the theater for exploration. You don't have to wait for CT scan. I'll go through this again by scenario base in the coming slides. If you just see the one picture which I've put it in the on right at the lower end, which you see there is no dislocation. You know, the one which is below the X-ray, there's no dislocation here, but you see extensive bruising and blistering. This should ring alarm bells. One must be very careful. It may be a spontaneous, maybe dislocation with spontaneous reduction. So this is something which you need to be aware of, and you need to correlate your findings, like the mechanism of injury, and then see the clinical examination like extensive bruising, and see subtle signs of radiological signs of subluxation, and then you will follow the protocol as a knee dislocation. Okay, this is the ankle brachial pressure index, why we need to do it. This is very accurate, reliable, and good sensitivity and specificity with a 100% positive predictive value, less invasive. It's non-invasive really. So which means you apply the ankle cuff, blood pressure cuff to the ankle of the injured limb and upper uninjured arm, and then check for it. If the ABPI is below 0.9, then it is a must that we need to get a CT angiogram and get the vascular surgeon input straight away. If you see a picture on the left, extreme left slide, you see an angiogram which shows completely a blocked popliteal artery. But then if you see it there on the right picture, where the patient has a collateral flow, this is why a patient can have a pulse with the completely occluded popliteal artery. So it doesn't mean if there is a pulse, you can avoid it. Ankle brachial pressure index is very important, and this will pick up ABPI, which will be low, and therefore we can act accordingly and urgently. Okay, how do we reduce it? When there is a dislocation, you must reduce it. We reduce it under sedation. It should be gentle traction, trying to reverse the deforming forces, and not much, and do not apply any pressure on the knee, especially on the back of the knee. You can aggravate or cause a vascular insult yourself. So it should be gentle traction. What if you don't get it? If you're not able to reduce it, you need to take him to the theater with the vascular support, of course. Okay. What do we see here? You can see a dimple sign. You can see an arrow there, which is a postural or a lateral dislocation of knee, which means the medial femoral condyle has buttonhole through the capsule and has entrapped the MCL. So how much ever you pull it, you're not going to reduce it. In turn, you may cause more vascular damage by continuously trying to reduce it. So don't attempt close reduction. This has to go to theater. Same is the case with open dislocations as well. Try not to reduce in the hospital, in the A&E. Try to take to the theater as soon as possible. Okay, here are the scenarios. I'll just go through it one by one. So you can splint the knee. Some surgeons splint the knee in extension, which most surgeons do. Some surgeons try to flex the knee to about 10 degrees in a hinge brace, so that you can avoid posterior subluxation. Okay, the first scenario is, let's say there's the check X-rays are satisfactory. There's a well-felt pulse. What do? You don't need to do a CT angiogram. You monitor the ABPI, check for pulse. ABPI must be done every 2 hours for the next 48 hours to 72 hours. Check for the signs of compartment syndrome. If there is compartment syndrome, you take him to the theater for a fasciotomy. Okay, that's the next scenario. Check X-rays are okay. Check X-rays are not okay with a bit of a subluxation. That more or less tells that the knee dislocation, knee is not stable. You may have an intact pulse. Doesn't mean that you should leave it at that. You should get an urgent CT angiogram, and then take the patient to the theater, simply because there is a subluxation, which means it can push on the vessels. So you need vascular surgeons' help. It may not be, they may not be required, but they should be by the side. So you put an external fixator, reduce the knee, and if there is compartment syndrome, you can do fasciotomy. Otherwise, you don't need to. Okay, let's come to another scenario. No pulse at all. So there is no pulse. You just have to take the patient to the theater for surgical exploration. Here are a few scenarios which I'd like to mention. This is where I was confused during my exam, FRCS. So I thought I will just make it clear. Knee dislocation doesn't mean that every patient will have only knee dislocation. They may have multiple injuries. Let's say the patient has a chest injury and a knee dislocation. So he may not be amenable for a prone approach. He may not be able to put prone because of the chest problems during anesthesia, and therefore the vascular surgeon can do an approach from the medial side and can repair or revascularize and reconstruct the popliteal artery, and then you can do the external fixator. External fixator, whether you need to do it or not, who comes first, the vascular or the surgeons. Ideally, if it is a very unstable knee, to provide a strong bed, it is better to do an external fixator first, followed by vascular repair. But if the vascular surgeons think that they need to go first, they will go first, and we should be able to work around putting an external fixator. Let's say if it is an isolated knee dislocation and there is no other injuries. So the vascular surgeon wants to do it prone position. So in that case, you will have to put a lateral external fixator. Of course, you're going to put a lateral pins for your femur anyways. For the proximal tibia or mid-shaft tibia, you may have to approach using the Schanz pins from the lateral end and put an spanning external fixator, like you see on the picture on the right, on the top. So once you do the external fixator, you position the patient prone, and the vascular surgeons will repair or reconstruct the popliteal artery. So hope this makes it clear. One more thing that you need to be aware of is, will you need any compartment release when you have a vascular surgery? Well, the literature says that yes, you may need, or you may benefit with it, simply because we can avoid a reperfusion syndrome, and therefore releasing the compartments by using one single incision or two incisions, but vascular surgeons generally do it with one single incision on the lateral side. Right, okay. So prophylactic fasciotomy, elective fasciotomy, the results show that early fasciotomy has improved outcomes with patients with vascular injury, and it reduced the amputation rates. So common peroneal nerve injury, as we said, it is also one of the common injuries, around 25%, ranging between 5 to 45%. We have an algorithm which you can follow. In general, if you have an open dislocation, you will have the surgeons, specialist surgeons, plastic surgeons available, who will help you, who will help with a nerve repair if it is completely transected. But if it is a closed injury, you will observe. You can follow this algorithm, and by 2 weeks, when you're planning for a multi-ligamentous knee injury, if it's you can plan for neurolysis if there is an intact nerve, but still with nerve problems. You need to put ankle foot orthosis and closely observe him, regularly do the nerve studies. Worst case scenario, you may have to go back and then do a tendon transfer if there is no recovery of the nerve by the end of the year. Normally it is about a year that we take a decision to do it. Okay, now that we dealt with acute dislocations, we'll go with multi-ligamentous injury. How do we deal with it? So we've dealt with the patient. Patient is comfortable in the brace, but we need to assess the knee for a possible surgical intervention. What are the requirements that we need to have for assessing the knee? First and foremost is a physical examination. You need to assess the ligaments, see which is gone. It may be difficult when a patient who is 2-week-old, he may not cooperate as much because he may be in pain. MRI scan gives a lot of information in terms of what ligaments have been ruptured. If you please check the image on the right, it is a published stress radiograph for ligament knee injuries, comparing amount of opening on the medial side or lateral side, suggesting if it is a partial, complete, or involvement of posterolateral and posteromedial corners as well. So intraoperative stress radiographs are extremely useful, reliable, and post-reconstruction we can always check and then document as well if you've achieved the stability. Okay, imaging. If there is a fracture that you suspect, you will need X-rays. If not, you will need MRI scan, which is a gold standard. You definitely will require what ligaments are gone to plan your surgery. Non-operative management. The literature says there is no role for non-operative management as they have significantly poor results and poor functional outcome from non-operative management, and it should only be reserved to people with poor general health condition and elderly patients who doesn't have the reserves or may not be able to do an extensive rigorous post-operative physiotherapy. Okay, coming to the surgical management, what do we do? It depends on the timing of surgery. When do we do the surgery? Is it sooner or later? Two schools of thought. Some surgeons try to do this in as early as possible, around 3 weeks' time. Some surgeons do it in 6 weeks' time. Why 3 weeks? 3 weeks is what they call as early intervention, where you have a possibility. There is a possibility of ligament repair as well as needing reconstruction. Around 3 weeks' time, you will have all the systemic inflammatory process subsides, and the anesthetic risk also reduces. But the downside is going around 3 weeks' time operating, the risk of arthrofibrosis is slightly higher compared to operating after 6 weeks. However, the recent literature says you have higher functional outcome from early intervention than a late intervention. So late surgeries, generally around 6 weeks is where you tend to take up. You can't repair because the ligaments would have scarred up, retracted, so you have no other option but a reconstruction is the only way out. Okay, do we do all at one go, or do we do it staged procedure? Again, two schools of thought. Some surgeons do it single stage, some surgeons do it a staged approach. So single stage, which means repairing and reconstructing all the ligaments around 3 weeks' time. What are the advantages of it? It restores the knee kinematics. and decrease the risk of meniscal or corneal damage due to instability, which you may have if you reconstruct only few ligaments. Okay, it is, however, suitable for a young individual, motivated individual who is open and capable of taking an aggressive physiotherapy, because arthrofibrosis is something which is relatively at a higher risk if you do all at single stage in 3 weeks' time. Staged approach, where you can repair the ligaments, the collateral ligament, the extraarticular mainly. That's what the first stage is. You repair or reconstruct the extraarticular structures, and then rehabilitate, get full range of movement, and then try to do second stage by reconstructing the cruciate ligaments. Repair versus reconstruction. Yes, repair is only possible in the first 3 weeks. After 3 weeks, it becomes difficult. Why reconstruction of the ligaments after 3 weeks is preferred? The repair has got probably a slightly poorer outcome and failure rates compared to reconstruction. That's why reconstruction of the ligaments are preferred in the first 3 weeks. Although the soft tissue planes are not very distinct, we can still be able to repair at the time. PLC injuries, the literature says that posterolateral corner reconstructions are better than repairs, and they have much better outcome from reconstructions. However, there are some literatures who are saying the cruciate ligament repairs or have equal functional outcome to a reconstruction. Okay, what are the grafts that we need to use? We have autografts, allografts. We know autografts. We can use quadriceps tendon, hamstring tendon, bone patellar bone tendon. But with a multi-ligamentous knee injury, you require a lot of grafts, for which most of the surgeons would prefer to use allografts because you have a greater selection. On top of those tendons that I've mentioned, you can have Achilles tendon grafts, anterior tibialis tendon, posterior tibialis posterior tendon that can be used. What are the advantages? Because it reduces the surgical time. A multi-ligamentous reconstruction does take time, so any time that can reduce it, we can take it. So reduce the surgical time, reduce the donor site morbidity, as well as the postoperative pain. What are the disadvantages? Allografts don't come cheap, they are expensive. There is a small risk of disease transmission as the allografts, and the incorporation is definitely slower compared to autografts. Let's go to the principles of multi-ligamentous knee injury. What is the aim of the surgery? Is to provide a stable knee, improve the range of movements with physiotherapy, and bring him back to as normal as possible with regards to the knee. However, we need to prepare the patient about the expectations. We must have a true expectations. Ligamentous injuries are not that straightforward. You wouldn't be able to get a perfect knee straight away. It's a long process. The principles involve, first of all, identification of all the ligaments by stress radiographs, assessment, and MRI scans. Then plan whether it is going to be a single stage or a staged approach. Avoiding tunnel convergence, which I'm going to discuss in the coming slides, and tension sequence. These two are very important in multi-ligamentous knee injury if it is a single stage approach. And a supervised rehab program, which is half the job. Surgery is half the job, and I think rehabilitation is half the job. See, avoiding tunnel convergence. Let's say if you have all the ligaments that are damaged, you may need at least 4 tunnels on the medial side and 3 tunnels on the lateral side. Then you can expect how difficult it is to have individual tunnels and to avoid convergence risk. So for an ACL and FCL, the convergence risk is about 75%. And for tibia, the number of tunnels you may need to do is about 5. So the risk of convergence is very high. And if there is any convergence, the risk of graft failure is also very high. So it should be in experienced hands. Anatomical landmarks are very important. You need to have intraoperative fluoroscopy to help in better tunnel placement and orientation. Tension sequence. Again, different surgeons follow different protocols. This is tension sequence if it is a single stage. Laprod is one of Dr. Laprod is one of the very famous soft tissue knee surgeons. You can follow this. He follows this protocol. Generally, most of the surgeons follow starting with the PCL as it restores the central pivot, and then they work around it. Laprod starts with anterolateral bundle, the PCL with 90 degrees, followed by posteromedial bundle, and then he goes to FCL, followed by the posterolateral corner, ACL, and last is the posteromedial corner. You can see the number of interference screws that went in. It's a complex surgery, so you can expect risks, and the rehabilitation process also can take longer. The rehab process may take up to 12 to 18 months. For the grafts to incorporate, it does take about 3 to 4 months. The rehab process is very important. The surgeon must liaise with the physiotherapist, and the rehab process must be patient specific, based on the surgery performed, and the patient must also have realistic expectations, and he should have the patience to undergo the rehab process for at least a year. Complications, yes, you do have complications. The risk of iatrogenic vascular injury, nerve injury, meniscal root injuries if you're placing the tunnels, the risk of compartment syndrome, of course, painful hardware. This is relatively more common in the multi-ligament if it can range between 30 to 40%. Risk of arterial as it is more likely if you do operate early. However, it can be negated by rehab process. And the residual instability. Aim is to achieve full instability. There is a possibility that you may have some instability still remaining. Right, that's the end of my talk. I will take the questions from here. I will stop sharing the screen.
Thank you. Sorry, that's an excellent talk, very comprehensive. The discussions for reconstruction, guys, if you're reaching that level, it means you're doing really well. Get your basics right. The very beginning of this talk is the key points here. Once you have that correct, you'll go smoothly into the reconstruction talks. Is there any questions from anyone?
Yes, there is a few questions. Thank you, Srikanth, for the excellent talk. First question, what about if there is an intimal tear? Would you do anything different, or you would rely on the vascular input for that?
Yeah, thank you. Good question. So if you have intimal tear, you will identify, because you need to do the ABPI. ABPI will pick up if the blood pressure is going down, if it is going less and less. So if you do a CT angiogram, if it is an evolving intimal tear, likely that it can lead to occlusion. So careful monitoring, vascular input. Vascular surgeons will likely to take up this case, and then go ahead and repair it. If it is a small intimal tear, if it is not evolving, they tend to leave it. But most likely for an injury like this with an intimal tear, it is most likely to evolve and occlude the artery.
Okay, thank you. And for ligamentous laxity, how would you assess of 2.1 millimeter of opening? Because if it's 2.2, it will be grade 2. So how can you specifically and accurately measure the difference?
Again, it is difficult. It is difficult. You have to say 2.1 or 2.2. Whatever the published picture that I've just put in, it is for our purpose and for your assessment and instability. Or you don't go on everything on the stress radiographs alone. If you have an MRI scan which says a complete rupture, and you don't need to do it. If it is a partial rupture, and if it is 2.1, and if it is 2.1 to 2.2, and you may consider it, look, if based on how many other ligaments are injured, you may tend to leave it, or again, it comes down to the surgeon who assessed him at the time, and he thinks that, look, after reconstructing the other ligaments, if he thinks that okay, there is some instability, he may have further problems, then he'll end up reconstructing that as well.
Thank you. And if there is a vascular injury that's requiring repair, how would you time your ligamentous injury repair in relation to that?
Yes, so it's no different. So you do the vascular reconstruction or repair, and you wait for early intervention. If the patient is recovering, doing very well, you go ahead at around the time of, based on which surgeons, somebody are early, somebody are late. Some people may take it late. They just say, take it easy. I'm not going to put a tourniquet. So of course, after a vascular injury, you're not going to put a tourniquet by operating on it. You do a staged approach, or you do a single approach based on discussion with the vascular surgeons. In general, after the vascular repair, after 3 weeks, you still go ahead.
Okay. And where if the vascular surgeon is to operate a posterior approach, and the patient is positioned prone, where are the lateral pins put in the tibia? The position of the location of the lateral pins in the tibia.
You have to identify the safe zones, go through the safe zones. You can put the lateral just behind the anterior shin, which is on the lateral side. You go through it. One on the proximal, you can go proximally or mid-shaft. You're more likely to get away without any injury if you go slightly more proximal on the lateral side.
Okay, thank you. And if you have, after reduction, of course, if you have a distal pulse, a good distal pulse, and an ABI of more than 0.9, would you still go for a CT angio?
More or less, sorry.
Would you still go for a CT angio even if you have a good distal pulse and an ABI of more than 0.9 after reduction?
No, it is not necessary that you need to, if the ABPI is maintained of 0.9 or above, you don't need to. It is not an indication, an absolute indication to do CT angiogram, and you could rely completely on ABPI. Some institutions routinely do it. Let's take a scenario. You have a distal pulse during the dislocation. At the time there is no pulse, and then you reduced it and you got the pulse back. Mm-hmm. Some would say, okay, there is an injury. There was a pulse. It was occluded. Maybe there was an intimal tear. It may be evolving. I would like to get a CT angiogram, get the vascular involved early. That's an argument some institutions make.
So do you say the safest answer is to do the CT angio in the exam?
Not necessarily. It is not routinely recommended because it is, as I said, ABPI is less invasive, rapid, and it is so accurate that it can pick up, it's got 100% predictive value, excellent sensitivity and specificity. You don't have to go over CT angio. But if I don't think you would go wrong if you say, okay, I'd like to get a CT angiogram, and I don't think you will be you will have any points minus on that.
Yeah, so I would, from, how shall I phrase it, from experience from the vivas, both teaching wise and on the courses I've been and the exam, I do suggest that you do mention you would consider doing a CT angiogram, or at the least an MRA and MR angiogram while you're doing your, so depending on your access in terms of which hospital you're in and so on. But CT angiogram would be the safest answer. I do appreciate what you're saying, Sri. You're right. The papers do say ABI, but remember, we're dealing with all respect to my consultant colleagues, we are dealing with guys that defer to the vascular surgeons. And in a lot of hospitals, especially the major trauma centers, the vascular surgeons will ask for an MRA or a CT angiogram to assess the vascularity, even in a patient that has return pulse.
Absolutely. Yeah, some institutions do it irrespective of it. They just do a CT angio or MR angiogram.
It is the safer answer for the exam. It's also the safer answer for the patient. But I do appreciate ABIs can be dependent on a lot of other things. But then the flip conversation is a CT angiogram in a patient who's got renal dysfunction is a risk as well for a patient. So it's not the easy answer, but in the exam it is. Okay.
Is there any role of total knee arthroplasty in multi-ligamentous injury in patients older than 50 years of age, like of course a constraint implant or something?
Yes, it's a very good question. Somebody who's 50 years and older, and you probably would like to create at least the collateral ligaments instead of constrained knee. Again, it depends on the surgeon who's doing it, rather than going for a completely hinged, a complex knee. You can make the knee more primary and simpler, and then reconstruct the only extra-articular ligaments, medial and lateral collateral ligaments, and then rehabilitate the knee, see how he gets on as somebody who is 50 years, and then take it from there. If he's only 50 years and if he's doing reasonably well from the rehab process, and if he does not have instability, we can wait as long as he develops the arthritis, and then go for a primary knee arthroplasty.
Okay, thank you. That's the end of